All right, I think we can go ahead and get started now. So good morning and welcome to the IASLC World Conference on Lung Cancer press briefing for today, where we will focus on the Presidential Symposium, which were our top abstracts from the conference. So these are really what we considered the best science, but with a focus also on who we are as an organization, multidisciplinary, international. And so we were really delighted with the caliber of abstracts that we were able to choose from. I am the president of the IASLC, Heather Wakely. I'm also a medical oncologist from Stanford University. So we're going to we have four presenters who have just come off the stage in the Presidential Symposium, and they're going to be giving us a summary of their work and also give you opportunities to ask questions. To start, we have Professor Rachel Murray from the United Kingdom. She'll be speaking about the YES trial, which really focused on increasing tobacco quitting, so smoking cessation at high rates as part of their screening program. Immunotherapy and targeted therapy get a lot of attention. Surgery is really the key aspect of cure for patients with early stage disease. And Dr. Nasser Al-Torki is going to be focusing on a really important study that looked at reducing the type of surgery. So we've had a mantra for many years that we needed to do a lobectomy, take out an entire lobe. But there have been questions for patients who have smaller tumors, whether lesser surgeries or sublobar resections can be done. And he's presenting for the first time a very large study done in the United States, which was looking at lesser versus more surgeries, so sublobar versus lobar. So this is a really critical question. And as he goes through the data, you'll understand why it makes such a difference for patients. So smoking cessation, really critical to what we do at IASLC, because if we can prevent smoking, we can prevent a lot of lung cancer. And then a question around surgery and whether we can improve quality of life for our patients by offering them just as good of a cancer outcome, but with leaving more of their lung intact. And then there have been a lot of work in how do we improve outcomes for patients who have been identified at earlier stages of disease, knowing that surgery or radiation, but usually surgery is the most important aspect of cure, but we can do more. And what we do with more now are with the immune targeted therapies, checkpoint inhibitors, we have many names for them, but immune therapies. And so we have updates from one of the biggest, and it was the first adjuvant, so after surgery trial with atezolizumab. And then we have data as well, and these both have overall survival data from the NADIM-2 study, which was looking at giving the immune therapy with chemotherapy prior to surgery. We're going to ask that you please hold your questions until the end. You can type them into the chat box so that I can read them. There'll also be a video recording if we don't get to everything, and it will be uploaded to the IASLC YouTube page for easy reference later today. So without further ado, I'm going to ask our first presenter, Professor Rachel Murray, and she will be presenting her abstract, Personalized Smoking Cessation Support in Lung Cancer Screening Program, the Yorkshire Enhanced Stop Smoking Study, also known as YES. And I will give a little bit more background on her before she comes up. So she is a professor who specializes in tobacco control research in multiple health settings. She's currently the PI of the Yorkshire Enhanced Stop Smoking Study, YES, which is what the title is, which is the subject of her presentation today. She joined the University of Nottingham in March of 2004 as a research associate, completed her PhD in 2009, was appointed as a lecturer in the health policy and promotion starting in August of 2009, and then achieved a master's degree, promoted to adjunct professor, and then to full professor in August of 2020. So welcome.
Thank you, Heather. So yeah, it's fantastic that stop smoking intervention has got the kind of coverage at this conference in a presidential symposium, and I'm delighted to talk about it with you today. So yeah, I will refer to it as the YES study, but it's a study that looked at adding co-located and personalised stop smoking support to a lung cancer screening programme in Yorkshire. So smoking is the biggest contributor to lung cancer, and smoking cessation is the most effective way that we can reduce lung cancer mortality. But what we do find is people attending for lung cancer screening, probably only around 2% of people will get a lung cancer diagnosed through the screening programme. But what we do have is around 30% of people who have a treatable condition in the form of tobacco dependence. And this is a really fantastic opportunity that we can capitalise on that. And some modelling work in the US has calculated that adding a tobacco control intervention to lung cancer screening will decrease overall deaths by an additional 14% and increase the overall number of life years gained by 81%. So there's fantastic gains to be made. And what we also know is that lung cancer screening in itself might provide what we call a teachable moment. And a teachable moment means that someone is motivated to make a positive behaviour change in response to something else. So in this case, attending for lung cancer screening may motivate people to try and change their smoking behaviour and make a quit attempt. And the research has also shown that attending a lung cancer screening is in itself a motivator. So just going for that initial appointment. So the ingredients were already there for a really successful outcome. And the research is growing, but what there isn't currently is a consensus on how best to integrate stop smoking provision within lung cancer screening, be that in the United States, the United Kingdom, or anywhere else around the world. What we know from elsewhere is that using effective stop smoking support makes it 4 times more likely that people will quit successfully. And there's some growing suggestion and evidence that there might be a potential to use real personalised intervention in the form of lung and heart images that are collected during lung cancer screening as part of the toolkit, if you like, to help people quit more successfully. So that's what our study was set up to look at, so the YES study. And it's nested within the Yorkshire Lung Screening Trial in the UK, which is similar to the lung cancer screening programmes that are held in other places. In this case, anyone that was a smoker that attended for lung cancer screening was offered an immediate consultation with a smoking cessation practitioner, or an SCP that I'll probably refer to them through the rest of the talk. That was on an opt-out basis. So unless people specifically said, no, I don't want to see them, they would go through that doorway on their clinical pathway. And within that session, they would get behavioural support on a one-to-one basis with an SCP. And they would also be provided with pharmacotherapy, so maybe nicotine replacement therapy, or referred to their GP for Champix or bupropion. And we also offered e-cigarettes as part of our package of intervention. At this point, we talked about the YES trial, but we didn't do anything further, and people went away with the consent form. So for the first 4 weeks, everybody got the exact same treatment of this counselling and behavioural support and pharmacotherapy. When we saw people for the 4-week follow-up point, which is a standard measure, we'd collect their smoking status to see if anyone had already quit, and we use some exhaled breath carbon monoxide as a validation. And then people were consented to take part in the study, and if they consented, they went to either the control arm or the intervention arm. Control arm got exactly the same as they'd had already for another 8 weeks, so totaling 12 weeks. And our intervention group got the same as the control group, but they also got this personalised intervention, which was their own heart and their own lung images, which I'll show you in a minute, plus some supportive scripted communication from the SCP. We followed these people up at 3 months and 12 months, and we collected smoking status again, some psychological change variables, quality of life measures, and their healthcare usage. So this was our participant flow. So really briefly, 2,248 people who attended for lung cancer screening were smokers, and that's about 1/3 of the overall lung screen population. 2,150 were eligible for a referral to the SCP, of which 89% were seen on the mobile unit at the time of their appointment, and 84% agreed to receive ongoing support. If we look at the proportion of those who did agree to the ongoing support, we looked at 7-day validated point prevalent abstinence. These are people that said they were quit and had been quit for 7 days at the 4-week period. And 16.5% were validated as quitters, and that increased to 20% if we used self-report, so people telling us that they'd quit, but we couldn't validate it for whatever reason. And that gave us a cost per validated quitter of just under £415. But then it's all well and good the people who are really motivated, but this is a whole service level. So if we look at everyone who would have been eligible for the intervention, our validated quit rate was 12.4% at 4 weeks, increasing to 15% on that self-reported measure, with a cost for validated quitter of £523. So of this, 1,003 people consented to take part in the study, and they were randomized at the point they agreed to see our advisor. So we ended up with 476 people in our control arm and 527 in our intervention arm. Briefly, this is what individuals were shown as part of the personalized intervention. So on the left is an example of a heart image that we showed people. So the left-hand image is their own heart collected from the CT scan, and the white area is coronary artery calcification, which is part of heart disease. Now, that was really unintelligible to most of our participants. So what we did was we translated to an artist's impression of a heart, which is that middle image. And then the white highlighted areas have been coloured in yellow to translate to our participants what they were looking at. Similarly, on the right-hand side, this was an example of a lung page. So the first image, we would highlight areas of emphysema from individuals' own scans. And then in the middle image, where possible, we attempted to get an area of healthy lung. So what we were telling people is they have been damaged to your lungs as seen in this first picture, but there's still healthy areas of your lung that you can preserve in the second picture. Briefly go through, these were our participant demographics. So we had an equal split of males and females. The majority of our participants were from the most deprived group, as you can see in the second row. And we used something called the Fagerstrom test of nicotine dependence to measure dependence levels. And a third of our participants were in the least dependent category. Not unusually, most of our participants had a negative scan outcome. So their CT scan as part of the lung cancer screening was clear. There were no concerns. And about half of our participants said that they were really extremely or moderately confident that they would be able to quit smoking successfully. So there was no difference between our study arms on any of these factors. So the primary outcome of the study was 7-day validated point prevalent abstinence at 3 months after the lung health check. And as you can see here, we had 33.6% of our study participants who were validated as abstinent at this point, with a cost per quitter of £521.30. And translated across the usual care, we had a 30% quit rate with a cost per quitter of £412.80. Secondary outcomes are listed below in terms of quit rates, so self-reported at 3 months and then validated and self-reported at 12 months. There's no significant difference at all between any of the study arms. But what was really promising is that our 12-month quit rates were around the 30% mark. And if people have quit for 12 months, that's a really, really good sign that they're going to be quit long term. So the fact that it's remained at 30%, and they normally drop off as well as time goes on. So that was really positive. We looked in a bit more detail at our primary outcome, and what we found is this significant interaction around sex, in that females were significantly more likely to quit smoking in our intervention arm than in the usual care arm. And they were also less likely to quit than their male counterparts in the usual care group. There was an interaction around deprivation level, with all deprivation groups being more likely to quit in the intervention group, apart from our second least deprived, which had quite a sizable difference in the opposite direction, which is why we've not seen any significant effects in there, we think. And not surprisingly, those people who'd had a positive or an indeterminate scan, so something was wrong on their scan that they had as part of the lung cancer screening, they were more likely to quit as well. There was no difference according to the age of our participants or the pharmacotherapy or vaping supplies that they'd chosen to use. And very similar results were found at 12 months. We still have this significant effect of gender happening. There was an interaction around pharmacotherapy, but no real clear pattern about a strong winner or loser in that sense. And there was no effect anymore of age deprivation or the scan outcome. The other thing we looked at is the content of those booklets that I just showed you. So at 3 months and 12 months, people that had a normal heart scan, so not showing any evidence of heart disease, were more likely to quit than those that had seen any image showing heart disease. And those with normal lung images were less likely to quit than those people that were showing any signs of emphysema. So we've also conducted a process evaluation alongside the YES study, which is being led by the Cardiff University. And what we found that the provision of a co-located and ongoing stop smoking support with real compassionate care was really well received by our participants, and was key to sustaining that quit attempt. Having the drop-in phone calls on a regular basis were really important, and I think that became even more important through COVID, where a lot of our participants were more socially isolated than they would have been before. And everything was there on the doorstep for them when they went. They didn't have to go anywhere else to see a practitioner. They didn't have to go anywhere else to pick up their quit supplies. They also liked the fact that it was very holistic and compassionate, the care they received. There was no judgment. A lot of times, if you talk about smoking and lung cancer, there is a big stigma and a blame culture around that. And that's something we tried really hard to avoid, as does everybody that works in this field. And I think the final thing, the result we got wasn't what we were expecting. I think we were all optimistic that showing these heart and lung images would be really important. But I think when it came down to it, our intervention effect was diluted by how good the support the participants received in that first 4 weeks with the gold standard that they'd got. And actually people had moved along that journey by the time they received the booklet at 4 weeks. So just in conclusion, having stop smoking intervention as part of the lung health check in a real integrated manner was positively received by both participants, patients and staff. Having the physical presence and being convenient was a key strength, and also the fact that we delivered a high intensity intervention. These participants are, they've got long smoking histories. They've often got a lot of other things going on in their lives. And so a brief intervention or a light touch is unlikely to have been effective. The individuals may not be ready to quit at the point they attend for lung health screening. So our quit rates went up between 4 weeks and 3 months, which is a really unusual finding. But people are coming to lung health checks. They've got other things on their mind. They're concerned about what their lung scan is going to show. But having an ongoing support offered is really important, and we can pick people up at other points on the journey. It was really positive that around a third of our participants were quit at 3 months, and that was largely sustained. As I've said, that's a really good indicator this is a long-term behaviour change and not a short-term reaction to the lung health check and the lung cancer screening. Our quit rates are higher in those with abnormal scans, so it's really important to be working with these people who have got abnormal scans coming through to help them change their behaviours. And as you've seen, our intervention may be effective in females. And I think there's still some questions around that, about whether it's generalizable, why we found the findings that we found. But I think the one question that we don't have is that co-locating and doing an evidence-based gold standard stop smoking support within a lung cancer screening setting is just vital. It improves the cost effectiveness of screening. It's receiving, really good feedback from the people that take part, because some people think it's going to put people off attending. It hasn't done that. We've got good quit rates, but that needs to be a real holistic and high intensity intervention. And these just the acknowledgements. The acknowledgements are our co-investigators, particularly Matt Callister, who's the clinical lead on the study. And then on the right, these are the true heroes. These are the smoking cessation practitioners who are doing this day in, day out. And I don't know what they do with the people who set foot in the room that swear they're not going to quit smoking, come out with all their pharmacotherapies and then go on to quit. So these guys are doing an amazing job, and it's all about them. Thank you very much.
Thank you. And again, we'll be having time for questions after we've heard from all 4 of our speakers. Our next presentation is from Dr. Nasser Al-Torki, who will be presenting lobar or sub-lobar resection for peripheral clinical stage 1A, 2-centimeter non-small cell lung cancer, results from an international randomized phase 3 trial. Dr. Al-Torki is a professor of cardiothoracic surgery, director of the Division of Thoracic Surgery at New York Presbyterian Weill Cornell Medical Center. Following medical school in Cairo, Egypt, Dr. Al-Torki completed his residency in general surgery at the University of Chicago and subsequently completed a fellowship in thoracic and cardiovascular surgery. So welcome, Dr. Al-Torki.
Thank you, President Wakely. How do I put this in full screen? Oh, okay. So our trial is a trial that compared lobar resection, which is excision of an entire lobe, with a sublobar resection for patients with small early tumors that had not spread to the lymph nodes. And trial is a long time coming. It was conceived in 2005, started in 2007, completed accrual in 2017. So I don't think we're going to do this again. The standard of care since 1995 has been to excise the entire lobe for early stage lung cancer. And this has been called into question because we've got better imaging, better staging, and more screening. There's a randomized trial from Japan that had shown that doing a segmentectomy, which is one type of sublobar resection, is equivalent to lobectomy in Japan, and that was a much larger trial. So this is the North American, Canadian, USA, and one center in Australia trial. And the design is shown here. So patients get diagnosed with the small 2 centimeter or less peripheral near the edge of the lung cancer, seemingly without spread to the lymph nodes. They go to the operating room. The nodes get biopsied. If the nodes are truly negative, then they get randomized to either have the standard of care, which is removal of the entire lobe where the cancer is, or a sublobar, which is either a wedge, which is simply taking the tumor with a margin of lung around it, or a segment, which is a little more than that. And then they get followed for the primary endpoint, which is disease-free survival, and some secondary endpoints, which are recurrence rate, overall survival, and pulmonary function testing. Importantly, and presciently, we stratified the trial according to tumor size, according to smoking history, and to the type of cell type, histology. So we ended up randomizing 697 patients. 357 had a lobectomy, 340 had a sublobar resection. The two arms were fairly well balanced in age groups, gender, performance status, and for the stratification factor. And this is the money slide, which is the disease-free survival, which is the primary endpoint. And you can see that the survival curves are superimposable. It's a non-inferiority design, and the hazard ratio here was 1.01. At 5 years, the survival was 63%, 63.6% for sublobar resection, and 64% for lobar resection. I would hasten to say that 2/3 of the patients had a wedge resection, which is an operation long thought by the surgical oncology community to be not such a good operation, but in fact, it is in this instance. Then we looked at this subgroup analysis, looking at the various impact on disease-free survival of the various clinical factors such as age, sex, histology, location, is it what lobe it's in, and there was no difference. And importantly, when you look at the stratification based on tumor size, there was also no difference. All the confidence intervals crossed unity. This shows the recurrence rate in red between the two arms of the trial, recurrence or death from lung cancer, again, superimposable, and death from competing causes of death other than cancer, non-cancer related death in green. So again, overlapping. This shows the secondary endpoint of overall survival. Again, non-inferiority of sublobar resection to lobectomy was shown here. The hazard ratio was 0.95. Dr. Saji, who discussed this, suggested perhaps that there may even be an advantage to sublobar resection. We could not show that in our trial, but they certainly showed it in the Japanese trial, so that is something to keep in mind. The 5-year survival was 80% in the sublobar resection arm and 78%. And this is pretty much the overall survival that's reported for this cohort prior to this trial. So I think we're on the money there. This shows the recurrence rates. And the thing that is surprising here is that 30% of these supposedly early stage patients had a recurrence event. About more than half of those recurrences were systemic. So if you look, there was 103 overall recurrences in the lobectomy group, and more than half of those were distant recurrences. And the same is true of the sublobar resection group. So that's one issue. The other issue is that even though the number of the people who had local regional recurrences in the area of the operation was slightly higher after sublobar resection, which is not surprising, this was not clinically significant. It was not statistically significant, and obviously was not clinically meaningful since it did not impact the survival curves. Then we looked at differences in pulmonary function. One of the arguments of a sublobar resection is that you actually preserve lung function. And we found that using these two metrics, which are the forced expiratory volume and the forced vital capacity, there is some preservation of lung function, but not as large a difference between the pre and the post as you would expect, and certainly not a large difference between the two arms. I'm personally skeptical that we are looking at the right metric here. There are other metrics to consider that we've discussed before, like the functional metrics, like the 6-minute walk test, like pulmonary exercise testing. Perhaps we missed the boat on that one, but at least in this one here, there's no difference. So if you combine the results of this trial with the results of the Japanese trial, I think we have pretty strong evidence that in this cohort of highly selected patients, and it's important to point that out over and over, which is that these are patients who met strict eligibility criteria before surgery and during surgery. In that cohort, it's pretty safe and in fact advisable, in fact, the new standard of care to do a sublobar resection.
All right, now we have two presentations looking at immune therapy pre or post. And I think for the press conference, we're going to switch the order from what we did at the presentation. And our next presenter will be Dr. Mariano Prevencio. Dr. Prevencio will report on his abstract progression-free survival and overall survival in the DEEM-2 study. Dr. Prevencio is president of the Spanish Lung Cancer Group, head of the Medical Oncology Service at Hospital Puerta de Hierro in Madrid, and has been appointed to be an associate professor at George Washington School of Medicine and Health Sciences this academic year. He is scientific director of the Health Research Institute of the Puerta de Hierro Hospital, and a professor of medicine at the University of Madrid. Has received numerous awards and is very well known in the field of neoadjuvant treatment. So welcome, Dr.
Thank you very much, and good morning, everyone. I would like to present our NADIN study. This study is focusing locally advanced disease. Dr. Torki has been presented in earlier stages. This is in intermediate states. In this case, we have very poor prognosis in these patients. These patients have N2 affectation. This is mediastinal disease, and you can see this mediastinal disease in CT scan. And also we focus in T4 group, patients who have more than 7 centimeters maximum diameter, or involvement different, for example, heart or the diaphragm or other. These specific patients have very, very poor prognosis. We treat these patients with several approaches. The standard of care is treat these patients with chemotherapy, neoadjuvant chemotherapy as induction treatment, and then evaluate the situation, surgery or no surgery, or radiotherapy after that, or concomitant radiotherapy. In any case, we have the same survival the last 40 years or 30 years. Is around 30% of the overall survival of 5 years. And the preoperative chemotherapy, neoadjuvant chemotherapy, the absolute improvement is only around 5% no more. And we have shown several surrogates. For example, in my opinion, the most robust is the pathological complete response. This is when you can see any tumor cell in the resectable specimen after the treatment. But with using neoadjuvant chemotherapy, the rate of this response is very low, around 4%. Now we have very, very exciting results with NADIN-1 and other clinical trials using neoadjuvant nivo plus chemo or other immunotherapy with very high survival rates, and also high percentage of PCR, the pathological complete response. I mentioned before, it's in my opinion, very good surrogate. And also we have the data about the Checkmate 816. Clinical trials is developing patients with more early stages from 1B to 3A, but the results are very promising, improving the median event-free survival and PCR, but with more stages resectable disease. In our NADIN-2, I think there is more specific and poor prognosis in these patients, and two affectation, clinical affectation, histologically proof, and then also T4 disease. We presented at ASCO the primary endpoint. It was a pathological complete response. It was higher than the control arm. You can see here almost odds ratio 7.88. And this is the study design. Patients with locally advanced disease and two disease, histologically confirmed and two disease. The randomization was 2-to-1, 2 experimental arm, 1 control arm. The surgery was performed after the 3-4 weeks neoadjuvant treatment was completed, and patients who achieved R0 surgery received adjuvant treatment for 6 months. These are the primary endpoint, the secondary endpoints. We have to present now the secondary endpoints because we have now 24 months of median follow-up. The baseline characteristics show no statistical differences between the two arms, but you can see here almost 72% have N2 affectation. I mentioned before, it is very, very poor prognosis in these patients when have clinical affectation and N2 affectation, and also multiple affectation, multiple station in half of them. This was the flow diagram. The randomization was 57 experimental R, 29 in control R. The majority of patients received the planned dose. And some data about regarding surgery, for example, the 93 patients underwent surgery versus 69 in control R. Odds ratio 5.96, very high significant range. And also the resection degree was higher in experimental R, 92.5% versus 65%, odds ratio 6.60, p-value 0.07. And also nodal down staging was higher in experimental R, 69.8 versus 40% in control R. The progression-free survival with median follow-up 26 months was longer in experimental R, hazard ratio 0.48, p-value 0.025. And as you can see here, the percentage of the progression disease in each of the time. And importantly, the PFS according to pathological response, you can see here the patients who achieve complete pathological response, no tumor in the specimen, all are free of disease at that time. And also we have data about overall survival, and also it was longer in experimental R, hazard ratio 0.40, p-value 0.03. And here the overall survival according to pathological response, and you can see 100% of patients who achieve PCR are alive at that time. Our conclusion is about the confer the superiority of nivo plus chemo in this setting of patients, in neoadjuvant setting, in neoadjuvant approach in these stages. The addition of neoadjuvant nivo plus chemo significantly improved the PCR, the pathological complete response, improve the progression-free survival, improve the overall survival, didn't impede feasibility of surgery with safety profile, and also is the first clinical trial with neoadjuvant immuno-based combination to show improved overall survival in these stages. Thank you very much.
All right, and our final speaker is Professor Enriqueta Felipe, who will report on Empower 010 overall survival interim analysis of a phase 3 study of atezolizumab versus best supportive care and resected non-small cell, so after surgery. Dr. Enriqueta Felipe is the head of the lung cancer unit of the oncology department at Vall d'Hebron University Hospital. She's held that position since 1995. She is the head of thoracic cancer unit and responsible for all lung cancer studies at her institution, and is a very well-known investigator in this and other fields. So welcome.
Thank you, Heather. So it has been an honor for me to present the results of IMpower 010, the overall survival interim analysis from this phase 3 randomized trial. So we previously know the disease survival in IMpower 010. This study included patients with resected tumors, not in the preoperative setting. These are patients resected, patients with a stage 1B with tumor size greater than 4 centimeters, 2 and 3A disease. And a patient received adjuvant chemotherapy, and then the patients were randomized to receive atezolizumab for 1 year or best supportive care. So we have previously presented data in disease survival, but today we have presented the first pre-specified interim analysis of overall survival. And also we have included safety analysis with more than 13 months of follow-up. So this is the design of the study that I just mentioned. Patients underwent surgery, then adjuvant chemotherapy, that is a standard, and then the patients were randomized to receive atezolizumab or no further treatment. The primary endpoint is the disease-free survival tested hierarchically. First, in a group of patients with a stage 2 and 3A and PD-L1 positive tumors. If positive, disease-free survival in all randomized stage 2 and 3A population. If positive, in a stage 1B, 2 and 3A population, and if positive, overall survival in an intention to treat population. We'd like to mention that disease-free survival in PD-L1 50% or higher stage 2 and 3A population was a key secondary endpoint. So these are the disease-free survival previously presented by Dr. Wakili Atasco and also published in Lancet with a data cutoff of January 2021 and a median follow-up of 32 months. So the study showed that for patients with stage 2 and 3A and PD-L1 positive tumors, atezolizumab improved disease-free survival with a hazard ratio of 0.66. In all randomized stage 2 and 3A population, the study also showed an improvement in disease-free survival with atezolizumab adjuvant with a hazard ratio of 0.79. And when we include all patients stage 1B, 2, and 3A, the hazard ratio for disease-free survival is 0.81. At the moment to analyze, the statistical significance boundary was not crossed. This slide shows the results of overall survival in the present interim analysis for overall survival for patients with stage 2 and 3A and PD-L1 positive tumors. So the data cutoff for this analysis is 18 April 2022, and the median follow-up of the patients is 46 months. So as mentioned, 30 months of additional follow-up when we compare to the prior presentation. So in this group of patients with stage 2 and 3A and PD-L1 positive tumors, there is a trend towards an improvement in overall survival for those patients receiving atezolizumab. The hazard ratio is 0.71 with a 95% confidence interval between 0.49 to 1.03. And as you can see, at 5 years, 60 months, there are 67.5% of the patients alive in the control arm, 76.8% of the patients in the atezolizumab arm. When we analyze all randomized patients with stage 2 and 3A irrespective of PD-L1, there is no difference in overall survival between the two treatment arms, with a hazard ratio of 0.95. When we analyze patients with stage 1B, 2, and 3A, there is also no differences in survival between the two treatment arms. If we focus on those patients with PD-L1 positive stage 2 and 3A population, we perform the subgroup analysis for overall survival, and in the vast majority of patients subgroup, there is a trend towards an improvement in overall survival for those patients receiving atezolizumab. It was mentioned during the discussion, even the subhistological subtype, we can see that for those patients with squamous cell carcinoma, the hazard ratio for overall survival is 0.85. For those patients with non-squamous, 0.61. For those patients with pathological stage 2A, a hazard ratio of 0.75. For stage 2B, 0.64. For stage 3A, 0.71. PD-L1 is important in a stage 4 disease, and we have analyzed the results according to PD-L1 in these patients with a stage 2 and 3A. As we mentioned, for patients with PD-L1 positive tumors, the hazard ratio for overall survival is 0.71. For those patients with PD-L1 50% or higher, a hazard ratio for overall survival of 0.43. For those patients with PD-L1 between 1 to 49%, a hazard ratio for overall survival of 0.95, and for those patients with PD-L1 negative tumors, a hazard ratio of 1.36. You can see the overall survival curves for the patients with stage 2 and 3A and PD-L1 50% or higher, excluding EGFR and ALK. Median survival was not reached in either of the treatment arms, and at 60 months, there are 84.8% of the patients alive in the atezolizumab arm, 67.5% in the control arm. Importantly, we have updated the safety from these patients in resected tumors treated with adjuvant immunotherapy, and with this additional 13 months of follow-up, the overall safety profile was consistent with the previous analysis, and no new safety signals were seen. So in conclusion, in our trial, we have seen an overall survival trend in favor of atezolizumab in patients with stage 2 and 3A population and PD-L1 positive tumors with a hazard ratio of 0.71 at the time of this pre-specified interim analysis for overall survival. In the PD-L1 50% or higher stage 2 and 3A population, the hazard ratio for overall survival is 0.43. Overall survival benefiting atezolizumab was not seen in all randomized stage 2 and 3A or in intention to treat population. After an additional 13 months of follow-up, the safety profile remains unchanged, with no new or unexpected safety signals. And these data support the previously reported positive benefit risk profile of adjuvant atezolizumab. This trial will continue to the final disease-free survival analysis and also overall survival, but we think it's really an important piece of information, such in this kind of trials, mature overall survival will need more than 10 years of follow-up. And thank you to the patients and the families.
Great. All right. No press conference is complete without hearing from the patient perspective. And so our final presentation today will be by our patient advocate, Christina Seat. So we'd like to have her kind of put this in context from what this means for the lives of patients dealing with lung cancer.
Thank you so much, everyone. And thank you to our esteemed panel and the members of the press for hearing me out. Today's presentation actually was very interesting as it went from early stage lung cancer, from screening all the way to surgery and treatment in order to reduce the risk of patients' reoccurrence. And the YES study actually was extremely interesting because it took personalized medicine to a really practical level. If you look at the Canadian Partnership Against Cancer statistics for low-income lung cancer patients, low-income patients had a 13 to 23% chance of lower chance of surviving 3 years over those with a higher income. And so the YES study actually was very, very practical because it took this treatment right to them. And it was specifically very significant to me was there was a quote that the presenter presented that said, you know, the treatment was presented in a very non-judgmental way. They were like angels that came in. And that corresponded very nicely with the study that was done by a social scientist, Ambreen Sayani from Canada, that really looked at patient preferences in low-income situations for screening and what their primary care physician said. And they looked at these, what they called pathways of disadvantage. Homelessness was one of them in terms of determinants of acceptance to screening. Others included job security. And the third one, the third big one, was physician judgment and clinician rapport. Did they feel like their clinician heard them, or were they talking to them? Were they with them, or were they working together with them? So that was highly significant, and I was very pleased to see that the quotes that had come out. The next presentation focused on surgery, which was very significant because it left patients with more of their lung, and hopefully we'll see later more lung function. But when it comes to health equity and lower income patients, some of these patients may have to go back to work very quickly because they are the only breadwinner in their family. So perhaps in future studies, we can also look at things like recovery time. How much time did it take before the patient could go back to normal life function as other indicators to help patient acceptance? So then the next two presentations were very exciting to me also because it really wrapped patients in a bubble and really helped prevent the risk of reoccurrence so they could spend more time with their family. But we know that the levels of risk that physicians perceive are different than the levels of risk that patients perceive. And so when in Canada, what we have something called health technology assessment, where we apply for reimbursement, and there is an arm that talks about patient preferences. So when the very first of these treatments came out and we looked at patient preferences, mea culpa, I made a very big mistake. I assumed that, there's a treatment, it's going to give them less risk, more time. Of course they would take it. But I was very surprised to see that over 50% said, you know what, I have to think about it. And I was like, why? Why would you have to do that? And one of them said to me, I said, well, is it the cost? What would happen if you didn't have to pay for it? And she said to me, Christina, it's not the cost. I can't afford to pay for parking. Another patient said to me, you know what, I've done with my surgery. I'm done with my lung cancer. I want to put it behind me. So I think as we move into earlier and earlier treatments, we have to be very mindful of the patient mindset. And early stage lung cancer is very different than the mindset of those that are in later stage lung cancer. And then finally, I really want to touch on health technology assessment because all these wonderful researchers and clinicians have really given lung cancer patients a lot of tools to really live out their life and have more time with their families. But we have to get these passed and covered publicly because these drugs are very, very expensive. If you look at a Patent and Medicine Review Board report, annual report from 2020 from Canada, you will see that the 28-day cost of a medication for a cancer medication is on average now $13,000 Canadian. That was more than double that from 2015. And then they said it was more than triple that from 2008. So these costs are very, very significant. So how can we get these drugs publicly covered? Because many patients do depend on them. So is it that we can show in the clinical trial? Can the clinical trials help us? Can there be more real world application in the clinical trial? For example, in the ASCO working group, when they retrospectively looked at one of the lung cancer trials and expanded the eligibility criteria without compromising the trial itself, 88% of patients became more eligible. And significantly, it also included more older patients and more women. So can we use this as a way to get more patients that are socially disadvantaged by also including more collaborations and existing collaborations between these cancer hospitals and community hospitals where they can have the more personalized medicine and have more acceptance that way? Can we also include things like logistics in the clinical trials, or is it that things like the atezolizumab, where the discussant was saying, different modes of delivery. They were looking at an injection sub-Q versus IV. So that meant that perhaps paramedics or nurses could go to the patient's home to deliver treatment as opposed to having patients go to the hospitals. These are all unexplored questions, but I hope this is more of a beginning rather than a conclusion. And we know that in medicine and in treatment, the medicine begins with me and treatment, me is in the center. So I hope that together with you members of the press and all the clinicians together, we take up this mantle of shared responsibility in getting treatments to patients. Thank you.
Okay, we now have time for questions.
We have 2 questions from reporters in the chat.
Great.
First one's for Dr. Murray. Do you know why there were differences between men and women in terms of their quitting smoking?
No, is the short answer. I mean, certainly in the UK, if we look at this age group, quit rates are usually slightly lower in women than in men, but we're only talking a few percent. So why we've got such a difference within this trial, we really don't know. It may be purely down to the self-selection of who's taken part in the lung screening itself. So there may be differences between the males and the females attending for the lung screening, and that's something that will be looked at once the lung screening trial is a bit further down the line. But we haven't looked at it yet.
Thank you. Another question for Dr. Provencio. I noticed you collected stool samples in your trial, so I'm curious to learn if any analysis of the microbiome planned to see if there were a difference in responders versus non-responders.
Yeah, we have a very important program to translational research. We have some data from NADIL-1, and for example, we have a signature RNA-seq, and we have to convert the results in NADIL-2. Is also the TCR sequencing, different mutation, different behavior, the microenvironment. There are 3 aspects: the tumor, the microenvironment, and also the treatment. And we have to study the 3 aspects in the next step.
Thank you. Question for Dr. Wakely. Can you please comment on how the results from the 13-month follow-up data from Empower will affect daily patient care?
So that's a good question. It's not clear that it will change the approvals that we have, as was presented. This regimen of giving the atezolizumab after complete resection is available for patients in the United States, in Japan, in China, for patients with stage 2 to 3A disease, where the tumor has that PD-L1 expression of at least 1%. And in the EU and other parts of the world, they're using that 50% cut point, even though, as we heard today in the discussions, what do those different time point or cut points actually mean for PD-L1, especially when we have another adjuvant trial with pembrolizumab where the PD-L1 levels didn't matter. The data that we saw today for the first time with another 13 months of follow-up really confirmed what we'd seen with the first, but now we have had further time, and therefore we're seeing the overall survival data tracking with what we saw with the DFS. So it's not really surprising when we look at what we've seen in other adjuvant trials with chemotherapy, though, you know, maybe as more time goes by, we'll continue to see those curves separating versus what we didn't always see with chemotherapy. So I don't think it's going to change the practice patterns we have today, but it does, from my perspective, add further weight to where we've got the regulatory bodies approving that option for patients. There are many other trials looking at these classes of drugs in the neoadjuvant before surgery and adjuvant after surgery setting. And I think as all of those trials mature, we're going to get closer to understanding what these different biomarkers might mean and how we select patients. But very hopeful to see the overall survival.
Thanks. I have a question for Dr. Altorki, and the concept's already flying around on social media, and I think it'll be interesting for the press that if you have shown that less is at least not more, if less is equal, does that open the door for non-surgical techniques, for stereotactic radiation, for ablation, or I'm moving increasingly towards a world where we don't even need surgery for these early lung cancers?
Surgeon asking surgeon that question. Okay.
So I think what we have are robust results of sublobar resection in that group of patients. And what we lack is similarly robust results in alternative methods of surgery. And it would be very nice to have a head-to-head comparison, but these attempts have failed time and time again. So we'll be left with what we have. And I think it's fair to say that the results with surgical sublobar resection are quite strong in favor of surgery.
I have a question for. I have a question for Dr. Murray. That was very nice. I'm struck by the fact that your personalized images work so well, as opposed to when you go to the airport and you see the horrible images that are next to the cigarette packages. So I was wondering what your thoughts. So those probably don't work. And then, so my question is, what you're doing, why don't we do this more for everyone? What's one of the limitations to rolling this out at hospitals around the world?
So I think the major limitation in this is the time element that it takes. And it's not hugely labor intensive, but it's labor intensive enough. So we have a research radiographer that annotates all these images by hand and then kind of prepares a brief script for our smoke and cessation practitioners, because it's very much clinically led. But I think with the future of AI, and there's, it's certainly already out there in terms of identifying the emphysema and the coronary artery calcification automatically, then I think potentially, if there's further promise that's shown, and I think there's more research that's needed to prove either way whether this is going to be beneficial, then that's a potential way forward. I mean, anecdotally, the feedback we got from our participants who received the booklets was overwhelmingly positive. They absolutely loved it. We've got people who've got these images pinned on their fridges and up on their cupboard doors and everything. So all the feedback we've had as they've gone along is that it's been a really powerful motivator. It's just not come out in translation. So I think there is much further exploration to do.
Can I follow up on it? So was that study done during the COVID years? And do you think COVID affected your baseline quickly?
So we started before COVID, we carried on through COVID, and we've subsequently finished afterwards. And we've done some sensitivity analyses, and there hasn't been any difference actually, because I think there would be a proportion that experienced difficulties in quitting for their personal reasons through COVID, but then another population who would have had increased motivation through COVID as well. So I think they've just counteracted each other.
A question for Dr. Philippe. Did anything in the follow-up data surprise you?
Thank you for the question. I think I have to say that no, probably is what we expected. No, what we have seen, it's true that in the prior analysis we had a snapshot data of overall survival, the hazard ratio, and the hazard ratio for overall survival in this present analysis is improving, no, and this is what we are expecting with immunotherapy with the time. And I think also it has been important that the toxicity is exactly the same with this additional 13 months of follow-up. So I think, yeah, it's what probably we would expect in this study. Thank you.
Yeah, I'm really struck by the whole panel, how you all tell a story. We have better patient care because we have smaller surgeries, people stop smoking, and then we give them some sort of biologic therapy either before or after. So this is amazing. So I'll ask you, Enriqueta, the one thing you showed is it works for many, but not for all. And given that there are some toxicities and the cost, how can we figure out how to personalize this better? The discussant, Benjamin, gave a wonderful talk, and he talked about ctDNA. You can actually measure the tumor cells in the blood floating around, and maybe that can tell us who to treat or how long to treat. I'm wondering where you're at with that analysis and how you think that will influence practice in the future.
Thank you, Roy. I think it's really important. In fact, in IMpower 010, there are tumor samples in different time points after surgery. It was presented at ESMO IO initial results, no, with circulating tumor DNA in the patients after resection. And clearly what we have seen is that circulating tumor DNA presence is prognostic. But it's true there are some patients without circulating tumor DNA that also seems to derive some benefit with adjuvant immunotherapy. But we have discussed that we have new technologies now, and probably we need to reanalyze these samples with new technologies in order to know exactly which patients need these adjuvant strategies.
In addition, we are going to present in 20 minutes the relation with the DNA levels in Nadine trial 2, according to PCR results.
Dr. Provencio, we have a question for you. Dr. Provencio? Could you please comment on the differences in design between NATM2 and CM8116, especially regarding the impact of adjuvant Nivo use?
Yeah. The Checkmate 816 was developed in patients with 1B to 3A. Patients in NADIN2 is only patients with N2 disease and T4, no early stages. And also we have introduced the treatment with adjuvant treatment with nivolumab for 6 months. And in Checkmate 816, it doesn't apply. I think this is the most important aspect in the design, because A16 was amended based in NADIN1, and this is part of the family.
That's all. Thank you.
Thanks to our panelists too.